We'll begin, if we may. Just to start off on a bit of housekeeping, this meeting is being recorded because unfortunately there are a number of people who for one reason or another can't be on here. And actually, Dan and Matt, that includes our master's researcher into public engagement with this, but they will look at it later. So I'm sure it will be very helpful for him. So I hope if anyone's worried about that, please just stay on mute and with your video off, and that will be okay because it won't take anything else. If people could, we're going to have the two presentations from Mac and Dan, and then there'll be lots of time for comments and questions and discussion. If you can use the chat function, that will be fine, but there should be plenty of opportunity for verbal comments as well. What I would ask though is that everybody who's not speaking, if you could please stay on mute so that we don't have the awful howl round going on. Anyone got any admin questions? I won't do my airline host impersonation as we're virtual. But I don't know whether you've all seen the hot news today is that Jackie Weaver, who took control of the Hanforth Parish Council meeting, has the final inquiry has reported, and it says that she didn't have any justification in procedural or protocols for what she did, but she acted with a lot of common sense. I think that's a fair summary of what the report concluded. And she pointed out that she didn't actually exclude the people that she did. She put them in the waiting room, and it was a council vote that actually excluded them from the meeting completely. But don't worry, Lisa and David, you can tell Jackie that they're all right for South Woodham Ferrers Town Council. So without further ado, the background to this is, some of you may remember, we've had an awful lot of meetings over the years about the organisation of the NHS as it affects us here. And the last really big one was probably when we had the primary care groups or trusts or networks or whatever they were called, when there was the split of commissioning and provision of services. And you'll remember that Provide came out of that and took over all the services like the district nurses and that sort of stuff, the community nurses as they're now called. And as a result of that, my observation personally would be that everybody retreated into their silos with their individual aims and objectives and remits and budgets, and got on with it in splendid isolation. And it was only people like Ken and I who went round the board meetings of all of them and tried to do anything joined up. That is an overall summary, which may or may not be agreed with. But anyway, as a result, health and social care haven't done joined up as well as they could have done, if at all. The exciting thing, I think, out of the proposals for the future is that we're going to have people under the same roof and umbrella, with Mac conducting the orchestra, as it were, and Dan looking after a local area. And I actually think there's a chance for improvement out of this, but am I right or am I wrong? Is this delusion? I mean, this is the NHS and etc. So without any further ado, that is the background to this. Mac and Dan are now going to explain to us how it's proposed that this will work, and then we'll be able to see how we think it will affect South Woodham Ferrers and let them know what we want it to make sure it does. So Mac is the executive lead for the Mid and South Essex Health and Care Partnership, which will soon become the integrated care system for Mid and South Essex. I expect they'll tell you what Mid and South Essex is, so I won't prejudge that. And there will be a board to go with this system. and we're asking him to talk about the launch and future collaboration between commissioners and providers of all local health and social care and the organisational arrangements therefore. So welcome, Mac. Thank you very much indeed for being with us. Much appreciated. And over to you.
Well, thank you,
Peter. Oh, yeah, I was going to say, Mac, I did some slides, but having tried putting them up earlier, it means I can't see anyone's faces. So
yeah,
I'd say let's go for it. Yeah.
You put us right.
So just send us the presentation and we can send it out with the notes.
Yeah,
I'll do that, Peter.
I don't like the PowerPoints myself anyway. So first of all, thank you. Thank you for giving me the opportunity to be with you. Because I'm effectively Dan's little helper in the sky. Dan is the man on the ground that makes things work, and he's done that for a number of years. And that's why we've just confirmed his appointment as the Alliance Director for your bit of the patch. Well done, Dan. I'm very unpopular at the moment because I had 4 people doing Dan's job and Dan was the only one that was outstandingly good enough to be confirmed in the role. But it really is important that we get people of a high caliber that can sort things out at a local level, because the whole changes that the government have introduced are about making the NHS and social care more local and more responsive. I've sort of spent several decades now wandering around the NHS, bumping into amazing people achieving incredible things for patients, but they seem to be doing it despite the system, let alone with its knowledge or support. And I don't want our bit of health and social care to be like that. I want us to get behind the people on the front line and to listen to the population that we serve and to provide services that are wrapped around communities. And Dan and colleagues in Mid and South, with their work through the Dengie project and other things, have begun to do that. So I'm going to try and get the other bits to work the same way. The actual challenge, as I see it, is to take all the different parts of our public services and all of the different things that they bring together and make sure that patients don't fall between the cracks. The NHS has talked for years about seamless services, but actually they talk about that because at the minute patients can fall between things. So we need to bring together everything from healthy lifestyles through to the built environment, to education and employment, and local community assets, through to primary care, the services that GPs and others provide, right along into community services, and then secondary care and emergency care and social care. And we need to make sure all of those things come together in the way that people want at the time that they need them. Sounds easy when you just say it like that, but I'm not sure whether Catherine here, who's smiling at all of these NHS problems, is here as a fellow NHS worker like Dan or I, or whether she's here as a local resident. But glad to see you anyway, Catherine, because everybody who understands the NHS from the inside out knows that there are problems. And you don't fix those problems by building superstructures and reorganizing the thing. You get it by hunkering down and staying close to patients and staying close to clinicians and listening to what the patients and the clinicians tell you. And that's what Dan has been good at on your patch. And that's what I'm going to try and replicate in other parts of our system. Now, there's some things that have been done quite well over recent years, but the reforms that we're leading are supposed to be creating a different focus and a slightly different approach to helping people stay healthy and well, and to have services ready for them when they need them. So it's about supporting health and well-being. It's about bringing care closer to home and actually in improving and transforming the way that we presently organise services. I've talked about the sort of impact that we want to have. And I guess I'm probably Mac of 1,000 days. We're worse than football managers. We come and go in, drop of a hat. If I was lucky, I'd have somewhere between 3 and 5 years to get alongside Dan and Catherine and others and make a difference. But the difference that I want to make is that our bit of the health and social care system should be distinctive, because we can and will do things that other places won't. If we're like that, I think we'll have got somewhere. I want us to be attractive, because the huge problem that health services face at the moment is with their workforce. They can't get enough doctors and nurses and carers and people working with them. And if we make our bit of the service a great place to work, where people are appreciated for their skills and their commitment to patients, people will walk towards us and we won't have those recruitment problems. And then finally, I say we should be successful, because when you measure how we're doing, whether it be waiting lists or anything else, I'd like to think that we'd be somewhere between good and great, not ugh and oh my goodness, which is basically where our numbers are at the minute after COVID. So I've seen some really amazing things in this part of the health service and in care services in our part of Essex. That's what caused me to stay, because I can see the potential, but I'm trying to make those things happen. So I'll stop there, Peter, and I'll hand over to Dan, and he can paint in how his stuff fits in with mine, and then glad to answer any questions.
Could I just ask you to just paint a very brief picture of who are the members of the ICS and what that board is going to be responsible for actioning?
Okay, so we used to have 5 clinical commissioning groups across the patch, and each of them had half a dozen executives. So when I came, the first thing I had to do was say goodbye to my 5 predecessors, because we didn't need them when we brought them together into one organisation. And then I ran a process that took the 36 executives across the 5 organisations into a team of 6 executives, of which Dan was one. We will, in the new ICS, still have half a dozen or so full-time paid help professional managers like Dan and I, who will be on the board, and we will be accountable to the board for saying what we'll do and doing what we say. I've got a chairman called Professor Mike Thorne, who used to run Anglia Ruskin University, who I have to say is a fabulous chairman. I'm very picky about my chairman. And he will be the chair of the board. We'll have 3 non-executive members of the board, and they are lay people who are there to help Mike hold the executives to account. In addition to that, we will have what are called participant members from different sectors within our system. So if you think about primary care, for example, we've got in total, I think it's 158 practices, and obviously that's many hundreds of GPs and thousands of other staff that work in primary care. There will be a seat on the board for somebody whose skills and experience and relationships are in primary care. As you can imagine, they'd quite like to have more than one seat. And the question of which out of the thousands of people and the hundreds of GPs gets the seat is quite an interesting one, because the NHS traditionally thinks of representation. You know, I'll send you one and they'll send you one. You can have 2 from there and 3 from there. But we'd end up with a board with 50 people on it. So actually it's 1 for primary care. We'll get 1 for all of the acute hospitals we work with. We'll get 1 for each of the 3 local authorities we work with. We'll get 1 for community health and 1 for mental health. And I think that's about it, isn't it, Dan? Have I missed any from the list? So we'll end up with a board of about 14 people, the majority there to hold the execs to account, but half a dozen people like Dan and I. Does that help, Peter?
Is that okay, Peter?
Yes, thanks. I mean, I think my main point is to say that you're going to have the social care providers involved in it, people like the ambulance service.
Yep.
The mental
I missed
health
the ambulances, thank you.
The community providers, So the commissioners and all the providers of all of our local services are going to be in that body and given and represented on the board.
To a greater or lesser degree, Peter, because I need to tell you about the alliance component of that in a minute.
Yeah.
But,
okay.
Yeah.
That was really the point of trying to explain the difference that this is going to make by having everybody who we recognise as part of the patient pathway that we want to be seamless from a patient's point of view is actually starting to overcome the artificial boundaries of the providers and the people responsible for commissioning and paying for.
And Peter, those that were created by CCGs. And so if I give you, Peter,
please carry on.
Call a practical example. I'll give you I'm changing what I'm going to say to you now based on the way the conversation is going to go. So I'm going to give you just a few practical examples. So Peter knows me, Matt knows me, but I know many of you on the call actually, but some of you don't know me. And just to talk about someone else, to talk about my wife at the moment, she works as a community physiotherapist. She treats people with strokes, so people who've had a stroke. She generally sees them just as they come out of hospital, and she follows them up in their own home, in their community. It's called early supported discharge. And the idea is that by rehabilitating people in their own homes, you get better outcomes because people can perform better in their own homes than what they do in hospital settings. And the results are fantastic. Now, Catherine, you said you were from Wickford. Yeah, I live in Malden. Peter lives in South Woodham, Ferrers. My wife actually works in your neck of the woods, Catherine, in the Wickford, Basildon, Billericay, that kind of area. But they have an ESD service, an early supported discharge service in Rayleigh and Southend as well. Now, when people have a stroke, and John, you can back me up on this, generally speaking, it doesn't matter where you live. The impact of a stroke is profound and can be really, really profound. So one of the things I say to people is explain to me why 5 CCGs commission different early supported discharge services, such that if you have a stroke, the offer of the service and the rehabilitation that you get currently in Essex is different if you live in Rayleigh, to if you live in Wickford, to if you live in South Woodham Ferrers. You get a different service offer in terms of how you rehabilitate stroke. It's never made sense to me, Peter. And so one of the things that MAC is trying to do is bring a consistency to some of those large scale service offers that will mean that it doesn't matter whether you've had your stroke in Wickford, Rayleigh or South Woodham Ferrers, you can expect the same high quality outcomes wherever you are. The same is true of some of the areas you're involved in, Peter, major trauma, ambulances, but even in terms of hospital services. And we know, particularly after COVID, that we've got profound problems with hospital waiting times. So you think, okay, that makes sense. You bring those things together. But then there are a lot of things that make a lot more sense that you need to think about doing things locally. So now I'm going to talk to you about something else. And this is real, and this is something that bothers me. So forgive me if I get a bit kind of het up about it. But one of the other things that we talk about now at our alliance level, and I'll explain what an alliance is at the moment. But if I was to say to you, what's the biggest cause of early death for men like me in our area? I live in Malden, not 15 minutes from South Woodham Ferrers. What's the biggest, the most common cause of early death for a man like me in our area? What would you say that you thought it was?
Feel free to unmute and tell.
Heart disease, cancer, I don't know what you would think. The truth is, if you don't know, is suicide. I'm most likely to take my own life. And in Essex, we have a rate of suicide that is far higher than the national average. And it isn't a statistical anomaly. It's been higher than the national average for many, many years. Sadly, in the Woodham district where I live, where I'm raising 2 young boys at the moment, that average is amongst the highest in the country. And if you're a man aged between 45 and 49 in our area, you are significantly higher than the national average in terms of your likelihood to take suicide. 25 men per 100,000 take their own life. Yeah, that's the rate per 100,000 of men. So think about the number of men that we've got in Mid and South Essex, but in Mid Essex or in South Woodham Ferrers, who are aged between 45 and 49, and think how many of them are taking their own life and the problems that that entails. Only a third of those men will be known to the NHS. So you've got John on there, a GP, you've got Catherine on there who works in a primary care network, which I'll mention in a minute. Only a third of these men actually would ever have seen the health service. So they won't have even contacted mental health services. They won't have contacted their GP. 1/3 will have, 2/3 won't. So how do we address a problem like that? It's not, you can't address it as an NHS problem because it isn't an NHS problem. You can't say it's a council problem because it isn't a council problem. You can't say it's a problem in education. You can't say, you have to acknowledge that this is a problem that can only be addressed by lots and lots and lots of partners working together. And that includes you good people, that includes communities. So these new reforms acknowledge that you can't do that at the scale that I was just talking to. We can't go to MAC and say this big ICS needs to sort out suicide in Essex. It's too big a scale. So these new reforms create these things called alliances. And in our area, the alliance covers Malden, Chelmsford and Braintree. It's about 400,000 people. And the idea of the alliance is it can pick up on what are very localized problems and very localized issues that exist within communities. And it can harness the power of, I suppose the clue's in the name, an alliance of people that allow you to tackle things that the big organizations like CCGs have never been able to do. And so I think about that thing about suicides and I think, well, where would I go? Where would I go in South Woodham Ferrers for 45 to 49-year-old men to influence? Well, South Woodham Rugby Club would be a good place to start, wouldn't it? I could start making some connections there. I can start making some connections with the Health and Social Care Group. William de Ferrers. How many of the pupils at William de Ferrers have got a dad who's probably between 45 and 49? You know, that's how we've got to harness that kind of power to influence communities. Matt can't do that with every secondary school in Mid and South Essex with the big team. And that's why people like me and people like you guys exist to work in these alliances to start to influence issues like that at a local level. And the same is true that you were saying about integrated care, Peter, earlier, because whilst you would try and address the issue of suicide in men a particular way, you would address the issue of dementia care and how a patient with dementia may exist within a particular community a slightly different way with different partners, different people cooperating. So within our alliance, we've got many, many partners, and they include many of the people you mentioned, our community services, our mental health providers, but they also include some more unusual folk. We've got all of our voluntary sector groups represented as best as we can. But we've also got connections into things like schools and the police and things like that. And one of the things I'm desperate to try and achieve in our alliance is to make it an alliance that is incredibly well connected to its people. So we're working with Health Watch Essex at the moment. They're an organisation that oversee patient involvement or public involvement in the NHS. But I don't want that to be something tokenistic in Mid Essex. And in part, that's why I wanted to be here with you guys tonight. We need to ensure that everything that we do, we are speaking to our communities and our public, not in terms of telling you what we're doing. You don't want to hear me come along and say, this is what we're doing. what I need to be able to do with South Woodham Ferrers as a community is be able to come along to you guys with people like Catherine and say, these are the challenges that the people of South Woodham Ferrers are facing. This is what our data tells us. This is what our intelligence tells us. And then collectively, we have to say, well, how are we going to solve this? And it isn't what are you going to do, Dan, or what are you going to do, Catherine? It's what are we all going to do in partnership to try to improve some of these things. So that doesn't take away from some of the more sort of traditional NHS measures that you would expect. Yes, we've still got to make sure we've got good access to GPs. Yes, we've still got to ensure that we're getting our prescriptions right and things like that at a local level. But actually, we've got to do more, and we've got to harness the power of communities to tackle more things there. So when I was referring to Catherine there, the smaller unit again within these alliances is this thing called a primary care network, which some of you will have heard of, some of you won't. But a primary care network is not just a group of GP practices. Many people think, oh, that's a group of GP practices working together. It is, but it's much more than that. In theory, what it is it's a group of GP practices plus all the representatives of the population that those GP practices serve. So for us and for you guys, the primary care network that you will be part of is the Dengie and South Woodham Ferrers, and it covers around about 50,000 people, and that's a local unit. We tend to look at it subtly differently, and you would appreciate because of the geographies, the Dengie has its rurality, South Woodham being slightly different. But the theory is that myself, Catherine, people like Peter, people like you guys on the call, but then other people, the head of William de Ferrers, you know, the police force, the kind of community safety officer, we all start looking and thinking about South Woodham Ferrers with the city council and others to start to say, what can we do to improve the health and well-being of the population that we serve? And we won't just be looking at things like the NHS, we'll be looking further still. So we will look at things like housing, we will look at access to green spaces, we will look at our partnership with the leisure sector, with someone will have to tell me the name of the leisure centre, but there's Club Woodham and things like that. So the stuff that is real for people, that influences their health behaviours, that's the type of thing that we've got to start tackling, and that's the purpose of these alliances. And so for me, I don't see the alliance, Peter, I mean, there is a component of it that is similar to as Maxec has formal membership as per the board. But actually, the alliance is very much open to all people with an interest in improving health and well-being in our area. And one of the things that I've been keen for the alliance to do, there's two things that I'm really, really keen to make sure it does. The first is I want it to be accessible. So what I've said is, as COVID restrictions start to ease, I want the alliance to be hosted in places that people can come to. And what I mean by that is come out to the population that it serves. So not host it in a Wren House, if you know where Wren House is, where the CCG was in Chelmsford, because Wren House it's got terrible parking, it's close to nothing, and people have to make a real effort to get there. What I want to do is hold it in places that are close to the people that we need to hear from, and we need to understand their needs. So in future, one of my asks to you guys is, where in South Woodham should I come to hold it? You know, should I come to the school? Should I come to William de Ferrers? Is there another organisation maybe that I can go to? And to give you an idea, one of the last alliances we had before lockdown, we had in a place called Lauriston Farm. I don't know if any of you have heard of it. It's in Goldhanger. And Lauriston Farm is a community interest company. It's a biodynamic farm. It grows vegetables and it farms livestock. And the entire farm is created in such a way that it's run and gives work experience to young adults with learning disabilities and young adults who've come out of the criminal justice system. And it basically creates a sustainable farming environment, but allows those young adults to gain a skill and potentially gain something that they can go into. And we went to that farm and we took all the kind of people, what we call the great and the good, from all these different organisations. And during that day, we heard from carers of people with learning disabilities. We heard of the young adults themselves, and they told us the challenges about getting a job. And something so simple, I'll tell you how daft it is, that we found out on that day. If you're a carer of a child with learning disability, a young adult with a learning disability in Essex, and you want to look to find a work placement, they're like you remember kind of, you do work experience at schools, they give these adults work experience to be able to try and find a job that works for them. the way that the system was set up in Essex, it meant that it only searched within 5 kilometres of your postcode. So imagine you live in the centre of Chelmsford. What kind of jobs come up? All the jobs are in kind of office jobs, then, you know, photocopying or front of house, that sort of stuff, because that's how the system's set up. But what if you like farming or you like the outdoors, and that's where your young adult with LD wants to work? Well, nothing comes up. Now, interestingly, the guy told us about that, and the person responsible for it was sat around the table. So it wasn't a case of we'll take that away. It was, can't we just sort that now? So one of the other things, and my challenge to all of you is to hold me to account for this, because Mac will hold me to account for it. But one of the things that I do with the Alliance as well is I challenge them at the end of every single meeting. And what I say to them is, tell me now the 3 decisions that we've made today that are going to have a positive impact on the health and well-being of the people of in my case, mid-Essex. And if they can't answer that positively, then we have to question why we were even there in the first place, because that's what we're there for. We're there to make decisions that are going to have a positive impact on the health and well-being of the people of mid-Essex. So that's what the Alliance is for, Peter. That's hopefully gives you some real-world ideas and flavours of what it can do. And I think it's got enormous potential. But I'm the first to admit that it's not something that I can do on my own. I need the help of the people around the table. But more than that, I need those people to reach into communities like yours and like the people on this call to be able to really get right underneath some of those problems that are influencing our population and hopefully have a positive impact on them. And for the Catherine, I don't know if you want to introduce yourself, but I feel I've obviously referred to you a few times there, but Catherine is integral in helping us in the South Woodham Ferrers Dengie PCN, and so will be a key sort of partner for me in helping to do some of that. But do you want to say hello, Catherine?
Dan?
Sure.
Yep.
Hi, everyone. Thanks, Dan. Yeah, as Dan suggested, I'm currently working alongside the clinical director over in the South Woodham and the Dengie to support the primary care network and its development. And part of my role, that's not my only role, but part of my role is to work with PCNs to kind of accelerate their ambitions based on their local population need, as Dan has set out. And like we've already touched upon, PCNs nationally form part of the NHS long-term plan, and the whole additional healthcare professionals are being recruited to work on behalf of primary care networks. These include kind of advanced nurse practitioners, clinical pharmacists, mental health professionals, physiotherapists, social prescribers. And the idea is to introduce in this greater kind of skill mix of professionals, local people get the access to the support they need. Essentially, the ultimate aim of your primary care network and primary care networks in general is to deliver better health outcomes for the local population, as well as trying to touch upon and reduce any of those health inequalities. We recognise actually in the South Woodham and the Dengie, the clinical director and I, that the South Woodham and Dengie, even within itself as a PCN, the population needs are vastly different in both the Dengie and South Woodham, based on a number of factors, really. And it's our role to kind of champion that population health management and ensure that those needs are met across the whole patch. And as Dan was talking through earlier, we plan to kind of work alongside you guys, raise the profile of the patient voice in all the development of local services within primary care networks at real kind of local grassroots level. I'm aware that there's already kind of neighbourhood pilots over the Dengie, and we plan to kind of nurture, develop and upscale that. Our working model within South Woodham and the Dengie PCN is simple. We plan to collaborate with community nursing, adult social care colleagues, secondary care, voluntary sector assets, pharmacies, care agencies to develop a kind of live MDT integrated working model, allowing us to also kind of work smarter and ensuring that patients kind of get that wraparound service, whether it's health or social care, because we all recognise that actually the needs of both feed into each other directly. And we've talked a long time about working health and social care working more effectively. We hope that this is now the time that will happen, allowing us to get the right people supported at the right time, and also really key to what Dan mentioned, in the right place for them. So it's not always going to be those health inequalities when we talked about suicide are not always going to be people that come to us. We need to look at what are the issues in the local population and how can we address that? How can we proactively manage our population health within that? And if it means going to rugby clubs, then we'll be going to rugby clubs, you know. So that's kind of where we as a PCN kind of slot in to the wider picture with kind of Dan, and as Dan said, orchestrated by Mac and his team.
Peter, do you want to ask us to expand on anything, or we can take questions now, really? But
yeah, okay. Very quickly, very pleased to welcome you, Catherine, and glad you're inculcated in NHS jargon. So I will explain to those who don't know that an MDT is a multidisciplinary team. Well done. Sorry, I'm pulling your leg.
Well, if I may join in on the local jargon, I think I can see a Telecaster on one wall and a Gretsch beside it, and a Spanish guitar behind Dan. So I think we've got an array of musicians here as well. I too can techno speak.
Very good. Well, I hope you're practicing your baton, please. Catherine, could you let us have your email address sometime, please, just so we can make contact, etc. And thank you very much for explaining the primary care network situation so well. Dan, could you just say, you're an alliance director.
That's correct.
Could you just put it into the context of the area that the geographical area that you're covering?
Yeah.
Because I think what you've highlighted is that you've got a very much local approach. I just wonder how many places within that area there are, like South Woodham, where you need to try to do what this joined up admirably talked about, and how you're going to be able to achieve that with whatever team you've got to cover that's
a very pertinent question, actually, Peter. So in terms of the area that I cover, and I very much see myself as being, I suppose, it's funny when people talk about jobs and they do my job and they say what they're going to do. I'm not going to do any of it. I have to be the catalyst to allow other people to do. I'd love to say I could do stuff, but actually there's plenty of people around me who are far more capable of getting things done than I am. But where we've got to create that movement to make things happen, for me, covers the areas of Braintree, Chelmsford and Malden, and that is the district areas. So obviously Malden, about 65,000 of that 400,000 population, the remaining population split predominantly between Chelmsford, the biggest, and then Braintree. One of the things, the primary care networks within that, there are about 9. There are about 9 networks. So obviously you can get a sense that they're roughly 40,000 population that each network covers. I'd love to say that we could divvy, the map up of Mid-Essex into perfect 40,000 blocks. We can't. So in some cases, because of the way that, in terms of just common sense for these practices to come together, 40,000 seems to be around the sweet spot for getting clinical directors to be able to look after that group. So for your area, South Woodham and the Dengie, as I say, but other primary care networks in Chelmsford, in Braintree, in the Colne Valley. So the major areas, I suppose, that we focus on would be Chelmsford itself, South Woodham, Ferrers, Malden, Witham, Braintree, the Colne Valley, Halstead, those sorts of areas. But obviously we've got a lot of rurality in between. So when I say South Woodham Ferrers, South Woodham Ferrers itself includes the areas around it. So we mustn't forget about places like Cold Norton and Stowe Maris and Bitnaker and places like that. And likewise, and Peter, I suspect most people on the call already know this, but Peter's the biggest advocate for South Woodham Ferrers, as is Ken actually in this domain, is to say to Chelmsford Council, Chelmsford is not just Chelmsford City, you know. So don't forget, when you're talking about Chelmsford City, that you include in Danbury, and you include in South Woodham Ferrers, and you include in Stowe Maris, and you include in all of those places, like I say, because there is sometimes a tendency for people to think of Chelmsford as the city centre, and obviously the city centre gets a lot of hype at the minute, and it's got a lot of things going on. But actually, back to the point that Catherine made, the health needs that exist within the city centre itself in Chelmsford, or within the Melbourne district of Chelmsford, are markedly different to the health needs that exist in Stowe Maris. And I don't need to tell you guys that, because you know it, but people forget that. People assume Chelmsford and they think Chelmsford city centre. You know, you couldn't get further apart, could you, than Stowe Maris and Chelmsford city centre. They're totally different places, despite only being kind of 10 miles apart, or less than that even. So that's the geographic area.
Stowe Maris is actually in Malden, Dan.
It is.
Talk about Woodham Ferrers or...
Yeah, or any of them, Peter. And the reality is, people register across the boundaries with GPs as well. So you'll have people in those areas who are registered at the health centre in South Woodham. So this is this thing. It's geographies that make sense for people. And so if I'm back to that thing, if I live in Stowe Maris, or if I live in Cold Norton, the chances are I might come shopping at Sainsbury's in South Woodham Ferrers. You know, so that's the hub that I'm going to coalesce around. The chances are my kids probably go to school in South Woodham Ferrers. So it's communities that make sense to people, not that make sense to politicians.
And if I may, Peter, just to contrast that, my geography is a bit bigger, but in order to fit together with Dan and Catherine, I always say, whatever's going wrong is my fault. Because the things that span the whole of the health and social care system, that are problems that are common to all the different places, things like waiting lists and times, they're the things that I have to get stuck into to change and improve. And in a very serious way, I need to embrace the responsibility for putting those things right. So that they get done, because it's easy to point, down the street and say, oh, well, that's the hospital and that's the community. But your point earlier on, that's when patients fall down the cracks. So it genuinely is when people have got a problem or an issue around the way in which the whole system's working, they're the things that I am responsible for picking up, and that I really want to know about, so that we can tackle them together.
And Peter, if I can just come back on one more thing. The other thing that you asked me was how we're going to structure ourselves to do that. Now, at one point, I will show you and give you the names of a team of people that will be working with me to help do what we've just been describing. I can't do that at this precise moment in time, because we are consulting with our staff to move them into that new structure. But it wouldn't surprise you if I was to say that my hope is that following the consultation, that structure will, in my area, take a three-pronged approach. Three-pronged in that it will reach into 3 different districts, because it needs to liaise with 3 different district councils or city council, 3 different voluntary sector organisations, etc., etc. And then it will have, as it sort of reaches out further still, it will have individuals that will support individual PCN areas. So my hope is the likes of yourself and Lorraine will and Catherine, sorry, will not only be able to talk to me or talk to people like Kate or Michelle, who you already know, but we'll have almost a ladder of people, some of whom will be working with you almost permanently. You know, they will be out alongside Catherine all the time. They will be out in the school. They will be out with you guys all of the time, because their job is to really reach out into a community. Obviously, for me, I've got to cover the wider remit. But again, you know, any time that you're thinking, well, it would be really good if Dan was alongside us to voice this concern on behalf of South Woodham Ferrers, you give me a shout, and me or a member of my team will be there to do that. And you know that I've said this to you before, and everyone always thinks that I'm saying it to kind of butter you guys up, but South Woodham is relatively unique in having the kind of health and social care group. You know, I'm on your email list, so I get the emails that the health and social care group sends out. Not every town has a group like the health and social care group. Not every town has residents that are as actively engaged. South Woodham Ferrers is advanced in that regard in my patch. We've got other areas, you know, there are areas that are good, but actually, you know, it's again helping you guys to actually help other communities to do the same thing, because there are other towns and other villages in our area that need to create a bit more of a voice of the community. And what I've got to do is find the way into some of those. But it's not all about geography either, Peter. So the other thing is thinking about our communities that exist within mid-Essex that aren't defined by a geography. And that may be groups that are defined by ethnicity, or even things like sexuality, where how are people from a LGBTQ plus background experiencing services? How do you find those people? Well, actually, there are kind of inroads that you can reach those communities and speak to people from those different backgrounds to get their sense of what needs to happen as well, even though you may not be able to do that through a smaller geography like South Woodham or Malden or something like that. So they're the challenges that we've got to face. But any questions from anyone, for any of us, I suppose?
Thank you very much, Dan. Yeah, if people want to chip in, either raise your hand or wave or unmute, and hopefully we'll manage to get people going. Hopefully you can hear, we are very lucky to have with us two very active and influential people who are going to be very much the conductor and the subconductor. And this is the opportunity for us to say what we want from our hospitals, specialist services, down to what we want to see. I mean, for instance, I've just done the pharmacy survey. Now, I've been delivering meds for the last 2 years. They all need more space, because at the moment, all I do every time I go in is trip over lots of prescriptions waiting to be collected, which are all over the place because they haven't got this. Anyway, that's a minor problem. So do chip in.
Or don't, if we've done the job. I can see Susan laughing. Ken, you must have a question. You've never not had a question.
I do, but technically it's a South Woodham meeting. But I'll kick off if no one else has anything. I mean, you're saying all the right things, but forgive me, you know, I've met a few messiahs, in the words of Monty Python, in many times. I'm intrigued to understand a little bit about the kind of the extra bits, if you like, suicide being your example. If you go to the community and ask them what their wicked issues are, I suspect you're going to get half a dozen, if not more. How are you going to decide amongst the various things that you could choose to tackle? I mean, clearly suicide is something dear to your heart, but someone else might say what we really need to do is whatever. Yeah. How are you going to sort of balance that?
It's a good question, Ken. And so I think the answer is a combination of, I guess, sort of qualitative, quantitative data. So look at the data. So I am passionate about suicide, but at the same time, it bothers me that Essex has the highest rate in the country, amongst the highest rates in the country. That seems incongruent to me living in Essex. So the data tells me suicide is a problem. People tell me suicide is a problem, and the evidence suggests that suicide affects a ripple effect across families or schools, and we sadly had some teenage deaths in our area through suicide. That has a profound impact on a community. So I think it's a combination of talking to people and asking them what their priorities are, but equally looking at what the data says, and equally then kind of putting the two together to say, where are we going to get the biggest bang for our buck in health improvement? And I suppose it's not as simple as this, Ken. I wish it was, but almost to then create a list and say, well, we can't do everything at once. So let's prioritise and say, well, what's the biggest priority? And actually, you know, what Catherine was referring to earlier, if we look at somewhere like South Woodham and the Dengie as a PCN, suicide sadly does come out as being a high problem, hence I mentioned it. But also, you know, the issues of social isolation and loneliness are very big for our area and something that we would need to address. And equally, sadly, the data would suggest that childhood obesity is still a problem for us to address. Now, you can look at the lifetime impact of all of those things, and health economists would say to you, well, you should probably tackle childhood obesity first, because if you get it right early on, those children will live a longer, healthier life. But if you speak to people will tell you that the impact of social isolation, particularly in the more rural areas, some of which we referred to earlier, is profound in our area and has a major impact on families. And so I think for our sort of area, and I'm speaking now as mainly sort of South Woodham and the Dengie, the things that we would primarily be looking at are the issues around social isolation. That goes into mental health and loneliness and those sorts of things. Childhood obesity, and then suicide prevention. Now, suicide prevention goes into a much wider realm of mental health. But then if you go below that, Ken, actually, the people of South Woodham Ferrers, and John would know this because it's been the same for the last, probably the last 20 years, generally enjoy good health outcomes, are generally considered to be more affluent than average. But with that goes a lot of the lifestyle illnesses that we often see in those populations. And that will be things like diabetes, I was going to use an acronym and Peter was going to pull me up on it, but I stopped myself. So heart disease, those sorts of things, vascular problems, high blood pressure. And so those sorts of issues, strokes, as I said, that goes into the preventative agenda. And that's generally lifestyle factors of getting people to eat as healthily as they can, drink less alcohol, stop smoking, active diet, those sorts of things. So you can create a list, Ken, but you've got to augment that with what the population are saying as well. And you all know Lorraine Jarvis, Mac knows Lorraine Jarvis. Lorraine would also say build on what's strong in your community. So if your community really wants to address childhood obesity and you've got someone in your school who is hugely passionate about it, harness that passion, because actually somebody in a community who wants to make a difference in an area is far more powerful an asset than me or Mac. You know, they're the people that will make the change on the ground, and you folk will know those people and signpost us to them. So it's a combination, Ken, I guess.
Thank you.
Brenda, thank Ken, although you come from Chelmsford, we're all on the same side, mate. Brenda has posted, and she's obviously got the memory because she remembers that when Mike Gogarty spoke to us at our last public meeting, which was a little while ago, he said that adult obesity and diabetes were the biggest problems in South Woodham Ferrers, and he backed that up. Now, Brenda, you've got an opportunity, of course, that I know about to take that forward in the local secondary school place and get the youngsters to go home and take the message home to the parents as well.
And that's exactly right, Peter. And so they obviously adult obesity, stroke, diabetes is exactly those lifestyle illnesses that I was referring to, because the two things go hand in hand. And interestingly, I don't know when that was, Brenda, if you could tell me, but interestingly, and I don't suppose it would surprise many of you, the social isolation issue has clearly been exacerbated through COVID. And we've got this cohort of folk that I would call maybe kind of COVID anxious, who were possibly somewhat socially isolated anyway, who are now even more so. And Peter, you've told me about individuals in this domain that you know personally. And I think that social isolation, loneliness thing is perhaps become more prominent over the last 2 years than perhaps what it was pre-COVID. But you're dead right, Brenda. Those lifestyle illnesses are absolutely something that we need to tackle in the South Woodham area and surrounds.
Catherine had her hand up, but she's put it down. Does this mean that you covered your point?
Yeah, I was just going to kind of bolt on to what Dan was kind of talking about, and that's our roles as your PCN team, really, with the clinical directors, is to kind of really look into that qualitative and quantitative data around what are the health inequalities, where are they, and what do we need to do look into that. Now, the NHS looking into health inequalities is not a new concept. The new concept is to how we do that and how we approach those health inequalities. So previously, we haven't always looked at proactive management, because there's always been quite a reactive process to the NHS. So it will depend on what those are and how we kind of hook into those community partners, schools. You know, really simply, recently over in another area that I worked in, they had an issue with firearms licensing and suicide rate, because what was happening, they weren't linking directly in with the GPs, and it didn't take a lot of work to work with Essex Police to actually change that process, change the protocol, and the reduction in that harm rate has come down over the last couple of years. And you know, that's, we worked in silos previously to tackle health inequalities, and I think that's mainly the difference now. But that will be our role, to look at what are your health inequalities, and even if that's split down the middle to health inequalities in the Dengie and health inequalities in South Woodham Ferrers.
Mac has picked up on what I was PCN equals primary care network. Yeah, I think we probably hopefully picked that one up. NHS is actually a TLA, a three-letter acronym. Yeah, very good. Mac's on form tonight, chaps. I'll pick up one thing, which is, I'm afraid, a constant thing, and I know that it's something that people are aware of. But Catherine, if you could subscribe to the social media Facebook groups that South Woodham Ferrers abounds in, you'll find that on a regular basis there are many complaints about accessibility to the GPs and the phone systems. One of our surgeries made a noble effort, actually, and at least brought in a new telephone system with the December monies. And at least you know where you are in the queue now with them, and you can get through in the end. That is the biggest problem at the moment, certainly according to our social media. And the other one is the time that it's taking ambulances to arrive. So, for instance, I've just had an answer to a question that I posed for the last ambulance trust meeting, because I spent 90 minutes just down the road directing the traffic around someone who'd had an accident in the road, on the highway. We used to be able to prioritise people going to people who'd had an accident or an emergency in public, but now it's 90 minutes plus, and it happened to be a particularly cold day. So there are a couple of things which are definitely present problems that we are experiencing. We're not alone in that, of course. I'm not actually expecting you to be able to answer the ambulance one.
No, so, but certainly back to that, I suppose, issue previously where you know this, but the ambulance service were having to interact with 5 different CCGs covering our area. They will now at least have a single point of interaction through the ICS, which brings consistency, which is what, again, the ambulance service want. And again, I mean, there's no way of me justifying or defending that, Peter. It's not an acceptable situation. But you're right. It's not unique to South Woodham. It's not unique to Essex. It's not unique to the East of England ambulance service. It's something we're faced over the way. You know, Matt may come in on the wider position of the ambulance service, but my kind of role there again within that alliance is to think, well, what is it that we as communities can do in order to support our colleagues in the ambulance service? And there are things that we can do. We have things called community, again, I know you know this, but people on the call may not, but community urgent response services that we can deploy. And obviously we have volunteers like the kind of community first responders that can work. Now that is the bit of that service that sits at the alliance end. The wider configuration of the kind of ambulance service itself and how it will improve itself is the conversation that Mac will lead on our behalf.
Yeah, thank you. Catherine, no doubt you're going to tell us how you're going to answer the accessibility question. Sorry, I've got a comment. Susan Wakeling has said, patients at Crouch Vale are aware that there appears to be no GP presence in the afternoon to deal with any urgent inquiries. I think reassurance that face-to-face appointments with GPs will resume ASAP to the level they were before COVID would help. And what I would say to Susan is that all of the surveys, of which Ken and I saw one fairly recently, show that actually the percentage of face-to-face appointments is the same now as it was before COVID. The trouble is that the volumes have upped considerably, but it's still around about 65% off the top of my head that are still being seen. But that's a question that, again, Ken and I have been looking at, the way that perhaps digital and virtual means can be used to speed things up and improve things for those who genuinely say, I mean, there's been a recent survey that said that 90% of a particular cohort of patients actually preferred virtual to in-person. And that was a very large survey of a lot of service users of a particular digital system.
May I ask, I'm familiar with that survey where some people preferred virtual, and you're absolutely spot on with the statistics and the facts, Peter. But what is the sort of thing that people can't get to a GP for? What is the nature of the consultations that are the ones that are difficult to get? Because they're having to prioritise because of volume and because of infection control and other things. But what is it that's getting squeezed out that used to happen?
I'll start off. It's people ringing up on the day wanting what would have used to be the people who turned up for an emergency surgery in person, and now they've got to phone up to be triaged and get through. Now, different surgeries have different systems. So the one that I'm most familiar with, they will concentrate on the telephone lines between 8 and 9. And if you get through, then you can get an appointment until they run out in the morning. And if not, you can have another go between 1 and 2, and you'll get one that afternoon. They're really the sort of the drop-in ones. I think there is a dearth of longer term ones, and so people are probably having to ring up more often for things which could be dealt with as routine if there were only appointments that you could book within a reasonable time scale in the coming week or two. Does that sound fair to people on the call?
Yeah.
I was going to ask, Susan typed it in, is it?
That was what I just read out.
Yeah, John's got a hand.
Okay, John.
The way we used to do it wouldn't, of course, be practical during the pandemic, but we used to have a 9 to 10 open house, the old-fashioned sit and wait, unbooked surgery. So people who wanted to be seen, if they turned up, we'd have nurse practitioners lined up to see them. So they were always guaranteed that they would be seen on that day. And the thing that was really good about it was that you could take a look in the waiting room and you could pick out the people who really need to be dealt with quickly. And being an old-fashioned sort of GP, I don't think you can beat face-to-face consultations because you pick up so much more than you would on a telephone or even on a video consultation. And then we used to have the booked appointments. There were some booked appointments on the day, but there were also lots of booked appointments which you could have for chronic conditions. So you didn't really, you know, people with chronic conditions want to maybe book their appointment 3, 4 weeks, 6 weeks in advance. And to have a system whereby you have to phone on the day, and I know a lot of GPs have done that. They used to call it the advanced booking system, which wasn't terribly advanced because people at work had to sort of commit to take the morning off because they had to phone the surgery between 8 and 9. And then they'd eventually get through to be told there were no appointments, by which time they'd already missed the morning at work. So that was one side of it. The other side of it, we did a lot of email consultations, because that worked very well. Because a lot of people in South Woodham Ferrers work in the city, so they leave the crack of dawn, and sometimes they don't get back till quite late at night. And it wasn't sort of, although we did a sort of commuter surgery, a lot of people like to just email in. They'd send photographs of their skin condition or whatever, and that suited them very well. So I think you've got to juggle it and have lots of different ways of being contacted, ways of getting in touch with patients.
I think, John, I think that's what a lot of the GPs are still saying is, and they're somewhat recalibrating. The big difference at the minute is that walk-in concept they just can't do, because as we were saying at the start, the COVID rates at the moment in particular are so high.
Yes.
And you know, several surgeries, and obviously you can imagine this at Crouch Vale as well. You know, the moment a member of staff gets COVID, you can lose your entire reception staff or your entire GP staff almost overnight. And I know a lot of surgeries that have said that concept of the walk-in surgery, the nurse practitioner led kind of turn up on the day and you will get seen, you might have to wait. That's one of the big things that they're missing out on. They just can't.
You couldn't do that now.
You just can't do it. No.
Better event, wouldn't it? So you'll have to wait till things are back to near normal before you can.
I mean, Catherine may say, but I think they're recalibrating.
Sorry, that in which case, surely you've got to then improve the telephone system. You've got to have more lines and more people answering it, rather than just a few lines and a couple of people answering it, and everyone having to wait tens of minutes to hours.
And I think that's exactly that's exactly the key, Peter. I think now with it's not only, as you said, that the concept of walk-ins has gone and simply GPs cannot do it. They're not allowed to do it at the moment, but the demand has significantly increased. And you're absolutely right. The vast majority of our surgeries simply don't have the plumbing going into and out of the building. The other problem is because many of them are doing a lot more telephone-based appointments and triage, that ties up the phone lines that they've already got. Yes. There are solutions, digital solutions exist, but it takes a little bit of time to implement those and to bring those in. And there are cost implications. Granted, that isn't the barrier, though. It isn't the money barrier.
They got money to do exactly that in December.
I'm saying, Peter,
the occasional one's done at least something.
I'm saying money isn't the barrier in this case. It is getting the right systems in and getting the right kind of digital systems in. You're right.
One surgery, you've got a surgery that's actually at the moment gone back and said, stop sending us emails, phone in for everything.
Yes.
And then you can't get through.
You have to speak to a receptionist for a long time, because the receptionist has to slowly type out the whole history of the patient's condition, which will then be handed to someone who will phone the patient back. And so patients were getting around that, as you say, by sending emails in, and then the email route was blocked. So people end up waiting 30 minutes, an hour. Even people who have really serious ongoing conditions or terminal patients or whatever get caught in the system. So something needs to be done about it, because, as you say, judging from Facebook, that's one of the big bones of contention in South Woodham at the moment.
Sorry,
and not unique to South Woodham. Not unique to South Woodham. John, it's the number one thing that I get mentioned to me pretty much everywhere that I speak to. It is high on our priority list to try and help people like Catherine to try and sort that. I think the phone lines is a big issue, Peter, and we will endeavour to be trying to sort that. There is then more to it. The GPs adapting to essentially triaging everything is a new skill to them. And as you said, John, and I most of you know I'm a clinician as well. I'd concur with John. To me, nothing beats seeing a patient. You can ask all the right questions. You can look for your kind of what we refer to as red flags or yellow flags. But John will tell you there are always patients that when you see them in the flesh, there's that gut feeling where you think, hang on, there's something more that's going on here. And so all practitioners are learning and are adapting, and GPs are no different to any other practitioner, that they are learning to now, it is a different skill assessing somebody over the phone and trying to assess severity to being able to see somebody face to face. They've adapted brilliantly during COVID, but I think what we're starting to appreciate now is that irrespective of the status of COVID within society, we are not going to go back to exactly how things were prior to the pandemic. It has changed behaviours, and GPs are having to adapt on a permanent basis. And there's a medical education issue in that as well. But the phone lines are a #1 priority, Peter.
Okay, thanks. And I see that
right.
Susan's actually typed in the point that I think I just expressed.
Yeah.
And that's helpful. Coral, I saw waving, and I think that Ken had his hand up, so I'm going to take Coral first because she hasn't spoken yet.
Yeah, hi. Firstly, I quite agree with the things you were saying about the telephone problems, partly because I tried to get an advance appointment for my mum yesterday, and I got to the end of the dates that they were actually booking for sometime in May, and there was no appointments. So that's why you're getting so many people calling the surgery, because that's the only option they've got. On the other subject of more localised areas, because they are two of the areas that are in your alliance, I had cause to get a memory assessment for my 89-year-old mother, and expected to have to go to the Crystal Centre at Chelmsford. So I was quite pleased to be advised that I could go to St. Peter's in Malden. I thought, oh, great, that's nice. So actually, the lady that came out to do the assessment at home was from the Malden cherry trees, is it?
Yeah.
So she did the home assessment. Quite some time later, we had the appointment at Malden for the verdict, so to speak. And 4 weeks has gone by since that appointment, where the diagnosis was given to us verbally, but no letter to the surgery. And I have been on the phone, trying to ring them, and it turns out that despite the fact that there are telephone numbers for St. Peter's and Malden and the Cherry Trees part, they don't work. They are still on websites. You end up having to ring the Crystal Centre, because the admin for the Malden St. Peter's part is actually at the Crystal Centre. And you can't get through there either, because it either just rings and cuts off, or nothing happens at all. Eventually, I have managed to get to speak to somebody, and they have emailed through the diagnosis letter that was actually typed some time ago, that had just been sitting around because nobody had signed it. Now, it's nice having these local centres and having something nearer to home, but if it's not joined up, I mean, why is the admin going to Chelmsford? And they are clearly not equipped for it. They did say to me that they'd had a lot of staff changes. And I got the distinct impression that it was like the blind leading the blind.
Yeah.
So is it a case of not enough money? Or are we going to blame COVID? Or
No,
what is going on? Because there's something definitely not right somewhere.
I don't know enough. I just typed in the chat, Coral. If you want to drop me an email outside so I can maybe get a bit of detail on that, I'll look into it, because I can't tell you specifically what's going wrong. What I can tell you is the point that you've made, though, is absolutely right, and it's true of any service. So the concept of care closer to home, as Max said, is something that we want to try and promote through this ICS. But that is all well and good, providing, like you say, you've got then effective communication and follow-up. And often and again, John and Catherine would confirm this, it's not helpful at all for GPs when they're left in the dark about diagnosis of something, particularly something like dementia, if that is the case for weeks and weeks. So, like I say, what you've described is a problem. It's a problem that needs to be sorted. I don't know enough of the detail to tell you the answer to that now, but please drop me an email and I'll look into it for you.
Sure.
Because
Okay.
yeah, you know, what you've said is right. And I know, you know, Catherine's ambition is to increase the amount of services that we can provide locally, be that either in patients' own homes or in places like Crouch Vale. But we can only do that if we've got effective communication with those kind of expert elements that sit in our hospitals in many cases, or in the hubs in Chelmsford. So yeah, I'll look into it for you, Coral. I couldn't answer it with any certainty now.
Sure.
I think what I would say to both Dan and to Mac, and Dan will probably be more aware of me banging on about the ophthalmology department at Broomfield for donkeys. I think communication is a big need for improvement all round throughout the NHS and social care. Wherever you're trying to get through to, it's not easy. Websites don't get updated, telephone numbers don't get changed, you can't get through, you can't get to the right person, you get pushed from pillar to post. These are general experiences. I understand that admins, once you get to see the clinicians, we're usually very pleased. It's the wait and the delay, whether it's for an ambulance or to get to speak to the right person or whatever, or for the support to the services, which is essential and needs to be efficient. Having said that, and I'm not excusing you or letting you off the hook, I do appreciate the hit that side of things has taken during the pandemic, and particularly at the moment with all the staff absences, which is hitting everybody, postal delays in the Chelmsford area. And I know that people at the hospital have been phoning up about appointments a lot more because of the postal delays. So there have been some efforts. I'm not saying that it's going unnoticed, but there's an awful lot of improvement required on communications. It's always the first, communications and patient involvement engagement are always the first victims of any crisis. And I think that you do yourselves a disservice by that, as you know, I've said, so I won't bang on. Ken, what would you like to say?
Well, I want you to start with some good news, because we're being, you know, we're slitting our wrists after this meeting, aren't we? Today, and this is personal. I have an ongoing urology problem. My GP sent a form over to the consultant, advice and guidance, saying this is a situation. I think I should do this. What do you think? Because it's a specialist area. The response has come back within 24 hours, so something is clearly working there. So just a bit of good news. The problems of access, to me, it's twofold, and it's true in our part of the world as it is in yours. It's partly getting through at all, so actually getting to talk to someone about whatever it is you want. And then secondly, it's getting, if you like, what you want, and that's where a lot of this face-to-face comes through. If you can't get through, what you're creating, what is being created, not deliberately, is a whole group of people who are now giving up on phoning at all. And I know a number of people who've said, I won't be able to get through, I'm not going to bother. And I think they, to me, that's a real worry. And if you are going to address a particular cohort, then I would begin to worry about those. Just to pick up one point with Dan on the, cost isn't a problem on telephone replacement. I had a meeting with some Mid-Essex CCG colleagues where we put to them, was it possible to provide funding to buy out of an existing GP contract so that they could improve their system? The answer was, there is no money. That's what we were told.
Okay. Well, so on the latter one first, Ken, again, drop me an email with the specifics on that, and I'll look into it, because, as Peter said, there was GP access money made available nationally. That gets divvied up. There is money in the pot. What I don't know the specifics of that scenario and the costs involved, but farewell, thank you. We'll be in touch. No worries, John. But yeah, drop me an email, Ken, and I'll look into that one. The couple of other points you made. I think your point about people's behaviours being driven by their experience is really pertinent. I know loads of you know I play rugby, and I talk to a lot of the lads in the rugby club, and a lot of them will say to me, well, I went to A&E yesterday about, and it's usually a rugby injury, and it pains me. I'm like, why did you go to A&E? Why did you go to A&E? Well, there's no point bothering the doctor because I'll never get through. So their behaviour has been driven by experience. They to the point that they now just think, well, I've got nothing to do on Sunday. I'm going to wake up injured and hungover. I might as well do that in the A&E waiting room, and then at least I get an answer. Whereas if I know that I try and do something on a Monday morning, the chances of me getting an appointment are limited. I know Mac has spoken to. There's a chap called Will who works with us who leads on primary care. It is one of our number one priorities, Ken. It won't be overnight, but I think we are going to do what we can. And then the other thing that you mentioned was advice and guidance, and it's a shame John's just gone, but again, as a clinician, that is really a significant thing and something we are really working with our hospital hard on, because many GPs, many physios like myself, if you see something, sometimes all you want is that little bit of advice from the expert at the hospital. I've done this and this test has come back and shown this. Should I be worried by that or not? And the GP sends that off and sort of says, well, this has gone a bit out of kilter. What would you do? Quite often the consultant will simply say, well, try adjusting this medication, see how it goes in a couple of weeks. If it improves, great. If it doesn't, send them in. That type of advice is utterly invaluable to GPs, to community nurses, to practice nurses, and so on and so forth. So it's good to hear that you had a 24-hour response in urology. Urology performs pretty well. Dermatology performs pretty well, but not all of our specialties are there yet. But we're working with the hospital to try and do that and get that as a much better kind of response time. And hopefully that does make a difference. But I think Mac and I are both reading loud and clear that the telephony issue at the front line for GPs it's not only is it a problem for you, but Mac's also getting lambasted by people centrally saying why are people waiting too long in A&E. Peter mentioned the issue with ambulances. It's all intrinsically linked, our system. And if more and more people are turning up at A&E, like my rugby friends, because they don't think it's worth going to their GP, that clogs the A&E up. When the A&E gets clogged up, that causes a problem with ambulances offloading. When ambulances can't offload, there's no ambulances to respond to Peter's person who had the accident in the community. I know that sounds like I'm kind of trivializing that, but it is the system is symbiotic. It feeds off of each other. So something like that primary care access issue is really fundamental to so many of the other areas that we've referred to. So I read that loud and clear from you all this evening.
Yeah, I mean, it's wider than that. I mean, if we encourage more people to go to our pharmacists, that will be helpful. But then it spreads wider, the problem. So, I mean, how long are people having to wait for dental appointments, opticians appointments, those sorts of things as well have been hit badly by everything. And so you've got problems with sight issues, with dental issues, and inevitably people then finish up having to go to A&E because it suddenly becomes acute.
And Peter, you're dead right on that. And I actually looked at the data on that the other day. So people think of dentistry as being, there's some people who see it as quite trivial, but actually, if any of you have had a tooth abscess and had it go problematic, it isn't trivial. And actually admissions into intensive care, and people do go into intensive care, believe I don't know if you would all know that, but if people get a really horrible infected abscess in their mouth, it can be a real problem. It can put people into a really problematic situation very, very quickly. And actually, nationally through the pandemic, that has surged significantly. And the volume of people that have been going into intensive care and high dependency units with problems that are basically dental in nature, it's trebled. It's actually trebled. So you are right. One of the things that an ICS does, although not in its first year of existence, is more responsibility for oversight of those services that you referred to, dentistry and optometry, will actually devolve down to the ICS, but that happens in 2023 rather than when it first forms. So the likelihood is that, yes, Mac and I can take that away and speak to NHS England, but in a year's time, that team that I referred to that I called the primary care team, that won't just be GPs, that will be optometrists and dentists as well. So that's one of the other aspects of the reform.
Brenda has typed in another erudite and good point, saying people don't want to be triaged at all, but are happy with alternatives. So if you told folks where to go for a minor skin condition or there for a bladder infection, etc., they would be happier as they feel they're being dealt with and don't necessarily have to see a doctor. And
Brenda, that's absolutely right.
You know, and how many people, unfortunately, these days are going to A&E with things that really are minor and really could be dealt with by a pharmacist. And, you know, why isn't there a pharmacist almost at the door of A&E triaging them before they see the triage nurse?
So, Peter, you're right, and Brenda's absolutely right, but it's more than just pharmacists. And you heard Catherine refer earlier to these new roles that we'll see in practices. And you will increasingly now find that you won't necessarily see the doctor. You'll see the physiotherapist, you'll see the pharmacist, you'll see the paramedic, you'll see the nurse specialist, you may see a psychologist or the social prescriber. There is an increasingly more diverse team. And Brenda, it makes me happy seeing what you've written there. But equally, as a physiotherapist, I've still encountered situations where people have sort of seen me and sort of said, well, I don't know why I'm seeing you. I wanted to see the doctor. And with respect to Dr. Cormack, if he's still on there, and I'm sure he wouldn't mind me saying it, people would be better off seeing me if their back was bad first up, perhaps, than sometimes seeing the GP. So it's great to hear you say that, Brenda. But that's, again, where we've got to harness the power of kind of communities to try and get that message out more widely. And I think the other thing, particularly with pharmacists, Peter, is we've got to get consistency of that pharmacy response, because it's great if you go to a pharmacy that has a very proactive and good pharmacist. Again, going back to Ken's point about learned behaviours, if you go to the pharmacy once or twice and the response you get is, oh, I can't deal with that, you've got to see your GP, that reinforces don't bother trying the next time or the time after that. And so that's where you know Paula Wilkinson, I know you guys do, but that's where I'm saying to Paula, we've got to make sure that we've got consistency, not just saying what a pharmacist can do, but what are all our pharmacists doing? Because it's no good if that's only one pharmacist who works in the pharmacy. Is there one in Sainsbury's? I think there is, isn't there? But no. Is there not one in Sainsbury's? It's in the town then. But if only one pharmacist gives you a positive response, that's not good enough for people. We need that consistency. But that's a really good point, Brenda. And you know, keep kind of reiterating that message, because GPs need that message to get out there, that they don't have to see everything anymore.
See, again, it's about communication by the NHS. I mean, there's all this stuff, and slightly understandable, for instance, about privatisation. I mean, the point is that since 1948, at its inception, the NHS has been a working partnership between commercial, public and private organisations. We've always had GPs, dentists and people like that who are independent businesses. But we haven't, the education, information and communication, again, has not educated people. It's not Dr. Finley's case.
So Peter, what I will do, because we created a whole load of really good videos of those individuals that are in these new roles in primary care, essentially saying what it is that they can do. And so there's one of a physio saying, you know, if you've got back pain or knee pain, you can see this. I'll send them to you, and hopefully you can include them in one of your email updates to the group, because they really put the message across simply. They've been viewed quite a lot, but clearly still not enough. But if I can give them to you and you can circulate them, then you know, it helps get the message out. But nothing's better than word of mouth in the end of the day. So, but I'll take an action to send those to you, because we've got them.
Okay. Ken has made a very, very good point, and he knows me too well. There are several people here who've not said or asked anything, and he'd love to hear from them. So please do speak up or type up if there is anything you would like to say. Either raise your hand, unmute yourself and speak up. or wave. The trouble is I can't see everyone.
Yeah, I have to pan through.
Yes. We have heard from a reasonable. David, what about the PPG's point of view, please? Given that you're there.
PPGs in South Woodham.
What is a PPG? I suppose we ought to start off by saying.
Patient participation group. In the context of this evening, it's difficult. Our PPG at Crouch Vale has not met since probably pre-COVID. We've tried to arrange meetings. We did actually have one meeting with the practice manager amongst the a sort of selected number of us, a committee of us, if you like, because of the joining together of the two surgeries of Kingsway and Brickfields. But effectively, the PPG is on hold. The other thing which I could mention, if you want a PPG viewpoint, goes way back, and it goes to something that Dan said right at the beginning. When we're talking about what services are needed in the local community, it's useful to have the data which he talks about. And in the past, we've been looked upon as people who shouldn't have the data. You know, this is what we're going to do. This is what the data tells us, not we're showing you the data and this is why we're doing it. And it's this interaction. Again, with the PCN, we've tried to get in touch with them, but we've had sort of messages that say, go away, we'll deal with the PPGs, not with whatever. So there's a number of sort of issues, but we can understand with the COVID that PPG goes right to the bottom of the list. And there's not really anything that could be done about that.
No, I mean, David, what I would say, a couple of things. I mean, first of all, good to hear from you. And you're right, because as you know, I used to come and meet you guys regularly, and I haven't met you since the pre-pandemic. So I recognise what you're saying. If there comes a point that you do want me to come back out and speak with you, just give me a shout and I'll very happily do that. As to your point about the data, I fundamentally want to change that, David. You know, there's issues with certain data where, you know, if there's issues with confidentiality and stuff like that, fair enough. But actually taking that point that I made to Ken earlier about looking at what data tells us, but looking at what people tell us, I think you guys need to see that data, because you'll understand it in a different way to what I'll understand it. And I'll understand it in a different way to what the Director of Public Health will understand it. And it's actually when we all look at it and all interpret it in our own ways that we, you know, become greater than the sum of our parts. So, you know, I'm saying to you now, from this point forward, if people are being difficult in terms of giving you access to data, you know, give me a shout, because I want to change that. I need to change that. Some of it's learned behaviours. Like I say, if it's something to do with confidential data or something like that, then there's probably fair enough. But actually, a lot of the data we need to look at, the stuff that I'm trying to think, who was it who referred to it earlier? Was it Brenda or? Yeah, it was Brenda who referred to the stuff on obesity and diabetes and things like that. That data's often publicly available anyway, but you guys shouldn't have to go trawling public health websites to get it. We need to give it to you in a palatable form. And one of my team at the moment is working on what we call PCN profiles, but don't worry about the terminology. Essentially what it means is a very easy read format that says what the major issues are that an area faces. So South Woodham and the Dengie is something that, you know, is something that you guys will find useful. It's something that Catherine and Smitesh Patel, the clinical director, will find useful, but you need to see it and you need to understand it. And if you don't need to understand it, I need to find people who can explain it to you and make it understandable, because then, like people have done already this evening, you'll tell us some things that we need to do to change it. So, you know, I know Peter always kind of makes notes of these things, but do kind of hold me to account for that. So if you're finding that difficult, David, give me a shout, yeah, and I'll cut through it.
on holding to account, I might just point out that we still haven't had the debrief about the opening of Crouchvale Medical Centre, which obviously was opened in the November before of 2019 and was due to happen as COVID hit. And so we've never actually had that opportunity. And it obviously is one of these things that could easily slip. I think actually that in itself might be reassuring, because there's an awful lot of misinformation around saying it's not big enough when the development comes along of the new houses. Having said that, it probably won't be if Morgan get their way and build some others in just over the edge, but that's another story. Yeah. Certainly we know it was built at the time taking account of the agreed development on Radar Hill. But there's also still a few tweaks and, you know, little things that need to be looked at from that.
That's almost like you read the question that came up about taking into account growth. So
oh yeah, there we are.
It just comes up as an initial for me, SW, but
yeah, that's Susan. Yeah, I mean, yes,
so Susan,
we know that was taken into the design and build, the 1200 or up to 1500 that it might have been.
Susan, Peter's right though, and John referred to this earlier. It's fair to say for South Woodham, but actually for a few of the other areas, that planning was done pre-pandemic, and the pandemic has changed the way that services are accessed, as we've heard several times this evening. So there's certainly no harm in revisiting that, Peter. I'll have a chat to them. But again, Susan, that's something that you in time you'll speak to Catherine about, because some of that modelling, you know, we would have assumed percentages of face-to-face appointments, walk-ins, those sorts of things. Generally speaking, if you just think of doctors' waiting areas at the moment, they've been empty for 2 years because people aren't allowed to sit in them and wait. And so there's going to be a bit of a recalibration of that happens. And doctors and practice managers and business partners like Catherine up and down the country at the moment are kind of re-evaluating the use of space within centres, because obviously they need maybe dedicated areas for telephone or online consultation, which don't have to be as big and don't have to be to the same clinical standard as an area where you see somebody face to face. But equally, in trying to move some of that online consultation into areas that are more administrative in nature, that frees up space for some of those new roles that Catherine was referring to in terms of the physiotherapists and the pharmacists and things like that. So I think it's fair to say that it was taken into account, it was planned for that growth, but actually, like many things, I think there's a bit of revisiting that can be done in many of our practices around that. So good question though.
Okay, looking at the clock and not wishing to go on for the sake of it, I think we've covered a vast array of ground. I think it's quite interesting that Dan's actually picked up most of the questions and comments, and Mac's been able to sit back and take it all in. But that's not actually a criticism. I do think that hopefully one of the opportunities of this revision is that we're going to see improved local engagement. And I think we're blessed having Dan, because he's been around and knows the patch and obviously has the confidence of both sides. So I think that's helpful. And hopefully we need to be taking strategic issues in our area to Mac, which he can deal with, and then the more local stuff.
Yeah. And thank you for that, Peter. And I haven't been sitting idly by. No, just because it's really helpful to hear firsthand some of the things here. So Ken highlighted the advice and guidance, and it's working. A year ago, I had to jump up and down and make a lot of people unhappy because our performance on advice and guidance was just completely unacceptable. It had gone to pot. And for the reasons that Ken gave, we had to get it back. And Dan will know the people at the hospital thought they should do some other things first. We had a different view. And Susan's point about access to GPs and David's point about what's happening to PPGs, that some of our colleagues are going to come into the office tomorrow morning to emails that ask them awkward questions. Dan's already got copies, so when we got the answers, we'll share them with you. But they're really good examples of what are otherwise just general questions. And I've gone back and asked the specifics. So even for me, who was, listening and learning, there are things that I can do to push on general issues that where everything gets clumped together on the back of your experience. I'm really grateful for the opportunity to be with you. Thank you so much for inviting us.
Well, I'm great. I think we're really grateful to you for listening, and I think it's so good an example that we've had this opportunity, and you're already doing things. You've heard, and you're doing, and that's
well,
great.
As I say, anything that's going wrong is my fault, so I'm the person that needs to hear about it.
It's a very good attitude.
I'll definitely bring my my Gibson Les Paul. I live in a doctor's room in the week, and so I haven't got enough wall to put a guitar on it. And if I played one, all of the people trying to sleep off the night shift would be very unhappy with me. But it's nice to see such a musical group.
May I just say thank you for the two of you for giving up your time. I mean, I know from many meetings that the levels at which you have to operate. Can I say the best news I've heard tonight is that Dan is now officially Alliance Director. That is such a good appointment. From my experience of working with Dan, no, it isn't perfect, but my God, if anyone can fix it, I've got faith in him doing so.
Well said, Ken.
Thanks, Ken.
Actually, it's still officially a secret, but I bust the secret because I thought you people needed to know. But
I'll keep it a secret.
They tell me it will be announced this week, but I never trust what they tell me.
Right. I get the feeling that we've covered an awful lot of ground. I hope that everyone who's wanted has made their thoughts known either on the chat or whatever, and that there isn't anyone sitting there who wishes they said something or wanted to say something and hasn't had the opportunity. I'll just wait a little while to make sure that I don't get hit on the head.
And Peter, from my perspective,
Brenda's got a hand up.
Let me just unmute myself. Peter, I don't know, this is a bit off topic, but I'm going to say it anyway because I'm South African. And in South Africa, things work. You could ask Nikki about this as well. But in South Africa, if you see a specialist, he'll give you a 6-month, perhaps a year-long prescription for something that's wrong with you. That would then be passed to the chemist, pharmacist, and then you would just go to the pharmacist once a month and pick up your prescription. In this country, the specialist or whatever gives it to your doctor, who each month you have to phone so that he can contact your chemist, so that the chemist can give you a prescription. Then next month you must phone your doctor, and your doctor must give you a prescription. And for South African, that's bonkers, because in South Africa, a specialist would give your pharmacist a prescription, and you would just go to your pharmacist and cut out that whole crazy rigmarole from where I'm standing. And I know that's how it's been done for years here, but that wouldn't happen where we come from. Sorry. It's just an idea that perhaps could be used. Yeah.
Very good idea.
So I can help a bit with that one. First of all, the two reasons they don't facilitate it more. The first is there's a lot of research on waste that happens if you prescribe for too long a period. I'm not saying they're right, I'm just saying that these are the reasons. The second one is there are clinical governance worries on the part of doctors that if they leave people on long-term medications and they're not monitoring them carefully enough, they can cause clinical problems.
Okay.
My mum, for example, was left on the wrong medicine for a long time and had all her potassium levels go through the floor. But the good news here is I haven't often trusted some of the NHS technology, but I got the NHS app during COVID. And on there, if your doctors have put you on a regular prescription, you just tick 4 boxes and the prescription goes off directly to your pharmacy and you can collect it from there. So there is a route through the NHS app with a regular prescription to just be able to be on it forever, clicking the boxes when you need a renewal, and it all goes through electronically and you collect it from the pharmacy. If you go onto another app, they can deliver it to your home. So there are techno routes around it now, Brenda.
Okay, thank you.
And
It's
that's
just for me an extra overhead. That's what I was thinking for yourselves, you know?
Yeah, there are different regulatory arrangements, but I do. There are actually systems around, as you said, Mac, and I think what Brenda's showing, who's Brenda's a very switched-on person. She obviously hasn't heard about some of them, and that's another communications thing. Interestingly, I mean, we've now got the practice pharmacists. I mean, I had a 6-monthly review of my meds recently with one of those. So certainly you can get on a system where you can get your auto repeat prescriptions through. Yeah. Well, our system means that they have to be dispensed by a doctor.
I'm with Susan, not only on the Stratocaster, but also on the medication for heart stuff. And there is the system that I was describing to Brenda. The bit where that's going wrong is that the reviews haven't happened, and the practice ought to be having those reviews to check that the medication doesn't affect your bloods and things like that. But it does put it on a constant loop. What's going wrong there is that the surgery needs to get the reviews going.
Yeah.
I have to with
Have
Brenda.
you seen Susan's post in the chat?
Yeah, that's what he was referring to.
Yeah, lovely. Yeah, okay.
I have to agree with Brenda.
Yeah.
I mean, it is a crazy system. What used to infuriate me was someone would be seen at the hospital and the doctor would write, I'd like to see Mrs. Smith again in a month, and I've given her a fortnight's prescription, which I'd like her to stay on for 6 months. So then she had to come to the GP to get a prescription. For people on long-term medication, there's a compliance problem. If people have to go every month, they're constantly running out. You've got to be really organised to do that. To have a 2-month supply of medication is much better, but it's a real pain for patients, and somebody should look at it again. I think one of the problems is that the prescribing in general practice is sort of monitored by pharmacists, and I think pharmacists rather look upon it as a way of slightly, keeping themselves in business, because there's quite a big, hefty prescription charge. Every time a prescription is written, the pharmacist gets a prescribing fee, and the problem with that is, of course, if you're on something like paracetamol or soluble aspirin or a cheap drug like Ramipril or whatever, that's a significant proportion of the cost of the drug. So if prescribing monthly adds to the cost significantly. I know there's a balance in as much as you don't want wastage, but wastage is going to carry on anyway, because you're always going to get old people who are going to stick their tablets in a cupboard because they're embarrassed that they don't want the GP to know that they're not taking them. But I think we need to look at it again from the patient's perspective.
There's also the old chestnut of hospital prescriptions that have to be dispensed at the hospital pharmacy, which might either take a very long time to be serviced or is closed, and you can't then take it to a high street one. Having seen our local pharmacists on a daily basis for the last 2 years, all I'd say is that the work that's involved in dispensing is considerable.
And that work would be halved if the prescriptions were 2 monthly rather than monthly. Yeah. And the GP's work would be halved if they were 2 monthly.
Yeah, agree. Okay. I think we'll wrap up because it's very nearly time. Mac, is there any last minute you'd like to say about anything that's come up?
Not really, but
Okay.
it's been a pleasure. But thanks to Dan and Catherine for joining us. Thank you.
Okay, Dan, any last word from you?
Just to say, if any of the folk on this call represent other groups, you know, you have links into schools or clubs or societies or anything like that, and you want me to come along or do a Zoom or a Teams or something like that, I put my email in the chat earlier. Peter's got it. Give me a shout. I'm very happy to come along. Doesn't matter whether it's a daytime or an evening, we'll find some time. So if you want me to come and speak to a group locally, that's kind of why I'm here. So just give me a shout.
Thank you very much. Catherine, anything you'd like to say?
Just, it was lovely to meet you all, and I look forward to working with you going forward.
Okay, and you may have seen that Susan, who was a stalwart member of staff at William de Ferrers, and Brenda, who is a leading light in the PTA. You see, it's not just the NHS that has all these three-word acronyms. PTA is what? Parent Teacher Association.
You've got a KFC as well. You've got a KFC in South Woodham.
They were actually going around there. Some of the people wearing KFC T-shirts were going around the town doing a litter pick today. That was quite
good on them.
to see. And they had lots of, anyway, that's by the by. Right. Yeah. Thank you all very much indeed. I think that was an extraordinarily productive meeting. We covered an awful lot of things. Thank you so much to Mac and to Dan and to Catherine for coming along and giving us the benefit of your time, but also for the fact that you do show your understanding and engagement with our community and your enthusiasm and desire for that, and that you have listened and already some things are being done as a result. So thank you all very much indeed. Have a good evening. Keep safe and well, everybody. And thank you ever so much. And we look forward to having another one of these in the not too distant future.
Thanks, Peter.
Happy Easter.